Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis. HPB cancers. Think A to G. Our specialist is Mr. Thomas Satiadas. A. Ask about symptoms.
There are no specific symptoms as such. Now, you could argue the jaundice, when the patient presents with jaundice is a sign. You could use that, but by the time the patient is jaundiced, quite a significant number of proportion of patients they are quite late into the diagnosis. Now, weight loss is a symptom which we are concerned. Weight loss with back pain, again, once you have back pain, there's quite a significant proportion of those patients who would have late presentation of disease, i.e. advanced disease. So we can't always equate patients who have weight loss to pancreatic cancer, but weight loss with other symptoms like steatorrhea, which I think majority of us clinicians do not ask specifically that question about steatorrhea, which I think should be incorporated in our diagnostic workup. And probably also trying to, if the symptoms, whether it's pain, weight loss, or jaundice, or new onset diabetes, all of those things which raise our antennae with regards to the potential for pancreatic cancer. But at the same time, the symptoms complex or the symptomatology is quite vague. Having an early review of that patient to see if the symptoms are persistent so that we can get the patients to access a CT scan, which could either reassure or get us to an early diagnosis.
B. Blood tests.
When we are talking about early diagnosis, your liver function test could be very much normal and a pancreas tumor could be small enough not to cause any obstruction of the bile, but thereby causing no jaundice. So normal liver function test does not mean much in this clinical context.
C. CT scan. We
have moved away from ultrasound because the sensitivity is not very good and the CT scan is the gold standard. So I would suggest, and we always say, that rather than wasting time or wasting resources, the better option would be to refer the patient straight for a CT. Ultrasound has definitely got a role in painful jaundice, where you might identify patients with gallstones, which are causing a problem. But if it's painless jaundice, CT is the best way forward. And also, if your patients have got vague symptoms, I would not waste resources by using ultrasound as a first imaging modality. I would go straight for a CT scan.
D. Diabetes.
Patients in the age group of 50 to 60 or more, or with new onset type 2 diabetes, or diabetes which have recently become uncontrolled, those patients with another symptom, with either weight loss or back pain or any other vague symptoms, we should be concerned of, and those patients would benefit from having an early referral for a CT scan. And I have to say, we are seeing more and more patients being referred in Greater Manchester with those signs and symptoms for CTs in the recent past.
E. Emergency presentation.
Percentage of patients with jaundice tend to casualty who have malignant diagnosis, and significant proportion of patients with pancreas cancer are presenting for emergency. Now, not all hospitals have protocols with regards to urgent CT scan for these patients, so quite a lot of patients would stay in hospital for many days before they have a CT scan or a diagnosis. So I think it's important that we have a protocol for them so that they don't have to stay in hospital for too long. But at the same time, quite a significant proportion of these patients who present via casualty are presenting at a very late stage.
F. Family history.
There are also patients who have familial predisposition, familial or genetic syndromes associated with. They also have a high risk factor for pancreatic cancer.
G. Greater Manchester Referral Proforma.
If the patients are not jaundiced and if there are concerns with regards to pregnancy, if they are sent in through the 2-week referral, we're still trying to run them through an RDC pathway. Now, I accept that not all hospitals have RDC set up at the moment, but that is the hope and plan from NHS England. We should have an RDC in most of the hospitals in Greater Manchester. We have also got a setting where in Stepping Hill, if the patient is jaundiced, they can come through the jaundice pathway where they'll have a scan done, i.e. CT scan done within 24 hours. And those are the agreements we are trying to create in local radiology departments and casualties. So if the patient even comes to casualty on their own with jaundice, if they are well enough, they could be given a slot in an RDC setting, or if they are unwell, they could be admitted and they go through radiology, i.e. have a CT scan before they go to the ward. The HPB form referral would be the ideal one if the patient's got specific symptoms and fall into that category. But at the same time, we don't want to make it difficult for primary care physicians to refer the patients, because quite a significant proportion of these patients have vague symptoms. So they could be accessed through the vague symptom RDC pathway as well.
HPB cancers. Think A to G. A. Ask about symptoms. B. Blood tests. C. CT scan. D. Diabetes. E. Emergency presentation. F. Family history. G. Greater Manchester Referral Proforma. GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.